Okay. All right. So this is chapter 25 on therapeutic drug monitoring. So we do some of this monitoring of certain drugs in the lab. So I think you might have seen a little bit if you were in chemistry. It's not all of the drugs, it's some of them. Okay, so we'll talk about the importance of TDM, therapeutic drug monitoring, and what is done in clinical laboratories. So this is really a multidisciplinary approach. So it's not just performed by the laboratorians, but also other members of the healthcare team, like the PharmDs, physicians, but it's a collaboration, basically. The PharmDs, or the pharmacists, are the people that deal with drugs, drug interaction, administration, metabolism, and things like that, right? But they wouldn't be able to see anything if we weren't doing anything in the laboratory. So it's very important that it's a collaboration. Physicians also take a big part of the drug regimen. They are the ones that prescribe and understand the way that drugs work and what they do. But PharmDs and pharmacists are the ones that are really hone in on those situations. So drugs are given to a patient for a particular condition. For example, a patient that has an irregular heartbeat. The doctor will prescribe a drug like digoxin. It's a cardiac regulator drug, and the dose needs to be checked with blood work. A drug like that needs to be monitored closely. The doctor will determine if the dose needs to be altered for that patient. So TDM is to ensure that the drug dosages are within a range that produces the maximal therapeutic benefit, and that's called the therapeutic range. And we also want to identify with TDM when the drug is outside of this therapeutic range. So when something is outside, it may lead to some detrimental results for the patient. So it could lead to drug inefficacy or toxicity. Sorry. So some definitions that you'll need to understand with the chapter is pharmacology and pharmacokinetics. Pharmacology is the science that deals with the origin, the nature, the chemistry, and the effects and the uses of the drug. And pharmacokinetics is the study of what the drug does or what the body is doing to the drug. So in pharmacokinetics, you see something like this: A, B, M, and E. A stands for absorption of the drug, B for distribution, M for metabolism, and E for excretion or elimination. So most drugs are not administered as a single dose, but delivered on a scheduled basis, right? So remember, when you take antibiotics, you take them every 3 hours, every 8 hours. Certain drugs you take every 4 hours, every 3 hours, things like that, once a day, once a week. So with this type of administration, the blood drug concentration kind of like oscillates between the maximum, which is the peak drug concentration, and the minimum, which is the true drug concentration. So the goal of the multiple dosage regimen is really to achieve the trough and the peak concentrations in the therapeutic range, and to ensure that the peak is not the toxic range. So pharmacogenomics is the science of studying the response variations and developing drug therapies that compensate for the genetic differences that impact the therapy regimens. Responders are the patients that benefit from the drug, the therapeutic and desired effects of the drug. And non-responders are the patients or the people that do not respond or do not show a beneficial effect from the initiation of a given drug regimen. Responders and non-responders are affected by the patient's variation in the genetic polymorphisms of their metabolism pathways. So genetics has something to do with the way that people metabolize drugs. So the body will produce a response to a drug whatever drug it may be that was administered. If we know the drug level, we can predict the response. So basically, by knowing the drug level, we also know the amount that's getting to the site of action, or we can predict the amount that's getting to the site of action. Okay, so one of the most prominent gene families that affect drug metabolism is the cytochrome P450, the CYP450. That is a genetic or a cytochrome, a gene. So the differences in rate of drug metabolism are attributed to the variations in the enzymes as a result of a genetic polymorphism. There are three variations that are associated with metabolism of drugs: CYP2D6, CYP2C9, CYP3A4. So we can use this information, these variations, to help personalize the doses of the drugs that are given to patients. If the patient's CYP450 profile indicates that he or she has genes known to metabolize drugs more slowly, then they would be given lower doses of that drug to avoid toxicity, right? Because they just can't metabolize it the same way. But if the profile indicates that he or she has the genes that predisposes that patient to an increased rate of metabolism, then that person would need an increased dose to maintain a therapeutic drug concentration. So basically, TDM involves the consideration of the route of administration. We also need to take into consideration the rate of absorption, the distribution of the drug within the body, and also the rate of elimination. So there are many organs that play a part here in the metabolism, the excretion, the elimination of the drug, but also genetics play an important role. Many factors influence drug absorption, distribution, and the rate of elimination. The process of achieving therapeutic drug concentrations, it's really not straightforward. So we don't all have the same methods of metabolizing drugs. So let's talk about some of the routes of administration. You may know a lot of these. The intravenous route is when you administer IV, right? IV administration into the circulatory system, and it provides the most direct and effective delivery to the sites of action. Bioavailability is the fraction of the drug that's administered or the dose that's administered that eventually reaches that site of action. Bioavailability. So you'll hear this or you'll read this term throughout the chapter. Intramuscular injections are drugs that are injected directly into the muscle. Subcutaneous are drugs injected right under the skin. Transcutaneous are inhaled or absorbed through the skin. Rectal delivery, that's mostly used in infant patients. And there are many reasons why. They have very small veins, right? And also because of injury. And oral administration. That's the most common route of drug administration, and it is also the least invasive route. So here are some of the factors that affect the circulating drug distribution. So you have the circulating free drug. We have to take into consideration protein binding of the drug, the bioavailability of the drug, the way the drug gets eliminated through the kidneys, the way the drug gets metabolized into its metabolites, the way it is distributed to the site of action, and its biologic response. Also, absorption, right? If it's an oral route, the body's mechanism for absorption takes a big part in the distribution and circulation of that drug. So let's talk about absorption. So the gastrointestinal tract is where the drug gets absorbed into the blood system, right? So this is when somebody takes it orally. Okay, and absorption in the GI tract depends on many factors. There's dissociation from its administered forms. solubility in the fluids of the gastrointestinal tract, and also diffusion across the GI membranes, right? So mostly, again, for orally administered drugs, if the person has already gastrointestinal issues, they are likely to have absorption problems. So the drug will not be distributed and absorbed and metabolized in the same way. Liquids tend to be more rapidly absorbed. For most drugs, absorption from the GI tract occurs in a predictable manner in healthy people. However, changes, again, in the intestinal motility, intestinal pH, if there's inflammation, right, like inflammatory bowel syndrome, those types of patients will suffer with issues of absorption. And when there's also the presence of food or other drugs that can dramatically alter the absorption rates. So again, let me go back to patients with IBS, inflammatory bowel syndrome. So patients with IBS may have some compromise, may have a compromised gastrointestinal tract, and it could affect the normal absorption of certain drugs. And again, drug absorption can also vary with administration of the type of drug, how it's administered, it can affect the GI tract. Some examples of those types of drugs can be some antacids, because it really alters the acidity of the GI system or the GI tract. So once the drug gets absorbed, the drug wants to travel to the site of action, right? So where it needs to work. Most drugs are subject to binding with proteins. So these drugs tend to form these drug-to-protein complexes. Only the free part or the unbound fraction of the drug can interact with its site of action and result in that biologic response that we are looking for. So basically, the free portion of the drug or the free drug fraction is the active form of the drug. So the total drug is what we measure, basically. And the total drug would be something like the protein-bound side of it plus the free part of it, right? So it's the protein-bound plus the free drug. So the free form, though, is what is responsible for the pharmacological action. So it's the active side, the active part of the drug is the free and unbound. Some conditions will affect the binding with proteins. A very big condition is the patients that have liver disease. And one of the major proteins that binds drugs is albumin. And so when patients have liver disease, you have to keep in mind that albumin is made in the liver. And so when liver disease is present, albumin is not made at the same rate, in the same manner, it's not as functional. So decreases in liver disease, it decreases in liver disease albumin, so less protein is available to bind, basically. In renal disease, I have no idea why this is going this way, but it keeps changing my slide by itself. Okay, in renal disease, patients also have a decrease in albumin and other proteins as well. So in both renal and liver disease, patients will have increased free drug levels. So less binding, more available free portions of the drug. The drug metabolism occurs in the hepatic portal system. Certain drugs are subject to significant hepatic uptake and metabolism. This is known as first-pass metabolism. It can be influenced by the individual's genetics, so that's something to always keep in mind. In terms of impaired liver function, that can reduce the capacity to metabolize drugs. So a lot of it gets metabolized in the liver, and that's why you always hear the liver plays a major role when a person takes a high amount of medications, right? So again, going back to people that have impaired liver function or liver disease, that also reduces the capacity for metabolizing certain drugs. Patients with liver disorders may require reduced dosages of the drug as the rate of metabolism and subsequent elimination process can be slowed down. Xenobiotics is a term that you'll read throughout the chapter, and they are exogenous substances that are capable of entering biochemical pathways intended for endogenous substances. So these are drugs, basically. Most drugs are xenobiotics. They are exogenous substances that are supposed to work like the natural substances that we have in our body, right? Usually drugs are given because something is missing, something is not working, and they are synthesized to mimic what's supposed to be happening in the body. So the biological pathways in which drugs can be acted on or biotransform are going to be discussed. One of them is the MFO pathway, which is also called the hepatic mixed function oxidase system. That's a mouthful. And this hepatic mixed function oxidase system involves taking hydrophobic substances and through a series of enzymatic reactions, converting these substances into water soluble products. So hydrophobic means these are insoluble substances, but through these enzymatic reactions, we convert them to water soluble. These products can then be either transformed into the bio or released into the circulation. Again, changes in the hepatic status can affect the concentration of circulating drugs eliminated by this pathway. Hepatic diseases states are characterized by the loss of functional tissue that may result in lower rates of clearance and a corresponding longer drug half-life. For example, a patient that may have cirrhosis, which is scarring of the liver. Okay. So drug elimination occurs in the kidneys. So the kidneys play a huge part here, and that's through the glomerular filtration or renal secretion, or both. It depends on the drug. Some drugs are not secreted or reabsorbed by the renal tubules. Most of these are the cyclosporin antibiotics. The elimination rate of a free drug directly relates to the glomerular filtration rate in the kidneys. Decreases in filtration rate of the glomerulus directly results in an increased drug half-life and elevated plasma concentrations of the drug. Decreases in the plasma drug concentration occurs as the first order process or the exponential, which leads to the exponential rate of loss. The rate of change of a drug concentration over time varies in relation to the concentration of the drug. So let me just go back to this to tell you that the kidneys play a major role in elimination and excretion of these metabolites once the drugs have been metabolized. So obviously, people with kidney disease and different issues with different functional kidney issues will affect the way and the rate that the drugs are being eliminated. So there can be possible buildup of a drug if the kidney is damaged. So there is certain drugs that really render some toxicity, like gentamicin and vancomycin are some antibiotics that if the patient already has kidney disorder and they're given these types of drugs, it can actually exacerbate the issue that they have in the kidney. So when people have kidney issues, the pharmacists, they work together with the physicians to make sure that the drugs that are given to these patients are not affecting the kidneys any more than what they are already affecting. And if so, the monitoring is very, very tight. So they'll monitor the patients closely if they have to be on this specific medication. So things like very strong antibiotics can damage the kidney. So more like, so they would be monitored closely. So this, so basically during elimination, the change in concentration per unit of time, so CT, is directly related to the concentration of the drug. So that seems pretty easy, right? The constant, which is K, is the factor that describes the percent change per unit of time. That's referred to as the elimination constant, or you could also call it the rate of elimination. And it's negative because it is a decreasing value. So this graph that you see right here shows a first order drug elimination process. The exponential rate of loss is present here on a linear scale. So what are some of the samples that we measure in the lab, in the clinical laboratory? Well, we measure times, okay, during TDM. So you have the peak drug concentration, and peak samples are drawn at specific times after the drug has been taken by the patient. You will see the highest concentration of that drug in the serum, and it's used for drugs that have a short half-life. You could also do a random sample. You can draw that at any time. And these usually don't have a set therapeutic range. So what are some of the reasons why we do this? Well, we want to look at the critical levels. We want to look at the toxicity levels, or whether there are any adverse symptoms present, and whether the drug needs to be discontinued, right? The TRUF samples are drawn just before the drug is given. And this is when the drug is at its lowest concentration in the serum. And when we measure this, we know that we are removing all the variables. And it's very common to measure the TRUF samples for oral drugs. So typically you'll see that we get a red top tube without preservative, which is the specimen of choice. Basically, the gel can cause some adherence of the drug, especially with drugs like anticonvulsants. These are the most affected by gel binding. Heparinized plasma is generally suitable for most drug analysis as well. Calcium binding anticoagulants tend to add a variety of anions and cations that can interfere with the analysis, or cause a drug to distribute differently between the plasma and the cells. The tubes that are unacceptable are EDTA, citrate, or oxalate. So what are the ranges? Where therapeutic ranges are the ones that provide the maximum desired effect without producing any adverse effects. Adverse effects, you know what they are. It would cause the patient to feel very tired, and it can get very complicated where the patient can lose hearing or vision. A subtherapeutic range are the levels of the drug that are right below the therapeutic range. A sensitivity level is the lowest concentration that can be detected by the assay, right? And usually it is based on 95% confidence interval levels. So that means that 95% of the people not taking the drug will be below the sensitivity level. A toxic range are when there are toxic or adverse effects of the drug above the therapeutic range. Critical is a life-threatening situation, so the physician will need to take action immediately, take the patient off the drug. A drug overdose, taking too much of the drug, and bioavailability, which I talked about before, is the amount of the drug that has been administered that will reach or will be available for the pharmacologically active, or will be the active portion of that drug. So some of the factors that we take into consideration, and these are the non-metabolic factors. So some genetic variability, the age of the patients, children versus babies, they have different types of enzymes, different types of flow. The sex, male versus females, and you would take into consideration the amount of lipid in the body, the amount of muscle mass, hormones, puberty, pregnancy, disease status, major factor. Body position, sometimes the way that the drug is distributed and metabolized can be affected by whether the patients are just laying down all the time, or they are bedridden, versus a patient who is mobile. And diurnal variations are also things to consider, right? So what are the counts in the morning versus the evenings? Oh, and this is important too, when we talk about certain drugs, is the generic versus the brand name, right? So the active chemicals are the same for both the generic names and the brand names. So for example, with digoxin, that's the generic, and it's the name of the active chemical. And Lanoxin would be the brand name, the popular brand name, right? So we always hear both of these, right, for a drug. So it's the generic name and then the brand name. And so with the generic, it usually tells you what the active chemical is of that specific drug. But then the brand name is sort of like the popular name and like what people will call it. All right, so drug-to-drug interactions. Drug can affect the absorption, the distribution, and metabolism, and the elimination, excretion of other drugs. So drug-to-drug interactions are also very important to consider. So just to give you some examples, there are patients that for maybe an example would be like a transplant patient, right? And so they just had a transplant and they are put on immunosuppressants, as well as perhaps blood pressure medication, maybe an anticoagulant, right? Maybe medication for to prevent seizures, or these are all very strong medications. And so when they are administered to the patients, they have to be accounted for in a very careful way, so that they understand how they're going to interact with one another as well. And so these are huge considerations, especially for those patients that have to take multiple drugs. So immunosuppressants are very strong, anticoagulants are very strong, but then patients like transplant patients and chemo patients, they have to take all these medications so that they can get by. So drug-to-drug interactions and those considerations are very important. So drugs can affect the absorption, distribution, metabolism, and excretion of other drugs. It can affect the drug metabolizing enzymes in the liver. Anytime you take more than one drug, the person is at risk for drug-to-drug interactions. The average 60-year-old is taking about 3 different prescribed medicines. So drug-to-drug interactions are things that they need to be. Sorry, guys. Oh, wait. Close the door. Hey, Mommy. Okay, sorry. I forgot to lock the door. Okay, so The average 60-year-old is taking 3 different prescribed medicines. All right, so timing is also very important. The half-life of a drug is the time it takes for the plasma concentration to decrease by 50%. A steady state is the drug that is in equal proportions everywhere in the body. So basically, 5 times the half-life of a certain drug can equals the steady state. So before assessing the drug levels, we have to make sure the patient is in a steady state. For example, with fentanyl, the half-life is 1 day. So when can you check the drug level for that drug? The drug level must be drawn relative to the time the dose was first given. When the drug is stopped, the level should be checked should be checked 5 times the half-life to see if it has cleared. So now I'll talk about some examples of certain drugs. We'll start with the cardioactive drugs. These could be cardiac glycosides and antiarrhythmic drugs, and these require TDM, so therapeutic drug monitoring, to achieve the appropriate dosages. So lanoxin or digoxin is one of them, and this is a common drug that is used to treat coronary heart failure and inhibits the membrane sodium-potassium ATPase pumps. It causes decreases in intracellular potassium, which results in increased intracellular calcium in myocytes and also improves cardiac contractility. So the range at which you would see effects of the drug is at 0.8 to 2 nanograms per milliliter. Higher serum concentration over 3 nanograms per milliliter is associated with adverse effects like vomiting, nausea, and visual disturbances. Absorption is variable and it's influenced by the patient's diet, the GI motility, and the formulation of the drug. About 25% of that drug is bound to protein. The free digoxin is sequestered into the muscle cells, and the tissue concentration is about 15 to 30 times greater than that of the plasma. Elimination can occur of these types of drugs by renal filtration of the free digoxin. The half-life of plasma digoxin is 38 hours in the average adult. Frequent dose adjustments with measurements should be done in patients with renal disease. Timing for evaluation of the peak digoxin concentration is very crucial. In an average adult, plasma concentration peaks between 2 to 3 hours after an oral dose. However, uptake into the tissues is slow. Plasma concentrations do not correlate well with tissue concentrations. Plasma concentrations of about 8 to 10 hours after the oral administration correlates well with the tissue concentration. Another example are the quinidine drugs, the Quinidex, Extentabs, also known as cardioquin or Quinora, but these are quinidine. And these are used to treat various cardiac arrhythmias. They are generally administered orally. Absorption is complete and it is rapid, with peak concentration in the serum achieved after 2 hours after administration. Common adverse effects or toxicities effect are nausea, vomiting, abdominal discomfort. Serious complications can include thrombocytopenia and tetanus. Measurement occurs of the measurement of this drug occurs with trough specimens to ensure that the serum concentrations are within the therapeutic range. Assessment of the peak specimens is performed only when the symptoms of toxicity are present. Other drugs that are commonly measured in TDM are the antibiotics. So we know that aminoglycosides are the types of antibiotics that are used to treat gram-negative bacteria infections that are resistant to less toxic antibiotics. These are pretty strong antibiotics. Some examples are gentamicin, tobramycin, amikacin, and kanamycin. Some adverse effects are nephrotoxicity and ototoxicity, so disruption of the inner cochlear part of the ear and the vestibular membranes in the ear. Administration of these antibiotics is typically through IV or IM, intramuscular. Peak concentrations are achieved in 1 to 2 hours after the first load, and the half-life is about 2 to 3 hours. Other examples are the teicoplanin. These are effective against aerobic and anaerobic gram-positive bacilli and gram-positive cocci. These are proven effective in treating MRSA, methicillin-resistant Staph aureus. They are administered through IV or IM injection. The half-life is about 70 to 100 hours, and the TDM is done mostly for dosage optimization. And vancomycin, another strong antibiotic, right? It's effective against gram-positive cocci and gram-positive bacilli through IV infusion. Peak concentrations are achieved in 1 hour after the dose. And the half-life is about 4 to 6 hours. This drug has a long distribution phase. Only trough concentrations are monitored to ensure that the drug concentration is within the therapeutic range. Other drugs that are commonly given to patients are the anti-epileptic drugs. These are prevalent in neurologic disorders for in the use for epilepsy or people with convulsions and seizures. These AEDs, anti-epileptic drugs, are used as prophylaxis, and therapeutic ranges are considered a guideline and should be interpreted in accordance with the present clinical context. The effective concentrations are determined as a concentration that provides a therapeutic benefit with no or acceptable adverse effects. Most of these anti-epileptic drugs are analyzed by immunoassays or chromatography and measure the free or bound drug in a serum or plasma sample. Some examples of anti-epileptic drugs are phenobarbital and primidone, valproic acid, carbamazepine, and then you can read the rest here. Some psychoactive drugs, I'll give you some examples of those as well. The first one is going to be lithium. This is a mood-altering drug primarily used in the treatment of bipolar disorder, recurrent depression, and aggressive or self-mutilating behavior. It's administered orally, and the peak plasma concentrations are reached about 2 to 4 hours after the dose has been given. The half-life is about 10 to 35 hours, and plasma concentrations of 0.5 to 1.2 millimoles per liter are effective in a large part of the population. Plasma concentrations of 1.5 to 2 may cause some apathy, lethargy, speech difficulties. Anything over 2 millimoles per liter are associated with renal impairment, hypothyroidism, and some central nervous system disturbances. So more drugs are the tricyclic antidepressants. These some examples are imipramine, amitriptyline, or doxepin, and these are used to treat depression, insomnia, extreme apathy, and loss of libido. These are administered orally. The peak concentrations are reached in the range of about 2 to 12 hours. Some other drugs are clozapine, olanzapine, and clozapine is used to treat schizophrenia. The therapeutic range is 350 to 420 nanograms per milliliters. And TDM is typically used for compliance of the drug. Olanzapine, it's a benzodiazepine derivative that is used to treat schizophrenia. Also acute manic episodes and recurrence of bipolar disorders. Some immunosuppressive drugs that are also given, and again, the clinical lab plays a big role in determining the success of any transplant program. So monitoring of these drugs is used to prevent rejection of the new organ. Most of these drugs require establishment of individual dosage regimens to optimize the therapeutic outcomes and minimize toxicity. So some examples of immunosuppressants are cyclosporin, tacrolimus, sirolimus, and mycophenolic acid. You might have heard of some of these. Anti-neoplastics. So with anti-neoplastics or cancer drugs, these are really not very much monitored with TDM. So TDM is not very useful in the assessment of the therapeutic benefit of these anti-neoplastic drugs because they are rapidly metabolized. The therapeutic range for many of these includes a concentration that's associated with toxic effects, unfortunately. Methotrexate is an example. It's one of the few anti-neoplastic drugs in which TDM may offer some benefit to determining the therapeutic regimen. It's effective in various neoplastic conditions. The way it works is that it inhibits DNA synthesis in all the cells. It's given in conjunction to glucoverin, which reverses the action of methotrexate at a specific time after the methotrexate infusion. And lastly, bronchodilators, theophylline. These are used in the treatment of respiratory disorders like asthma and stable chronic pulmonary disease. Patients with difficulty using, and also in patients with difficulty using an inhaler. So the absorption is variable. The peak concentration is achieved after 1 to 2 hours after the dose when a rapid release formation is administered or within 4 to 8 hours for a modified release preparation. The half-life is about 3 to 8 hours, and the beneficial effects are shown at the 10 to 20 milligrams per liter concentration. The levels above 20 milligrams per liter may lead to insomnia, tachycardia, seizures, arrhythmias, and possible cardiac arrest. Okay, so just give me 1 second. I am going to stop the recording.